ادعمونا بلايك للفيديو واشتراك بالقناة، فهذا يدعمنا كثيرا.
Although routine anesthetic techniques are usually effective for treatment of most pulpally involved teeth, some endodontic procedures present special situations that require additional techniques and special approaches. In these videos, you're going to observe how to administer alternative and supplemental injections in patients with pulpal and periapical diseases. The Gauge-Gates injection. When the conventional inferior alveolar technique has been unsuccessful, the Gauge-Gate injection is a good secondary injection technique for obtaining local anesthesia. This is not a substitute for the conventional inferior alveolar technique, and its disadvantages are A. It has a slower onset, and it is associated with more positive aspiration of hemorrhage. On the skull, note the superior position of the needle and the barrel of the syringe. The target zone is the anterior head of the condyle, which is a small target. Note the orientation of the barrel of the syringe, which is parallel to the inferior border of the mandible. On a patient, there are two landmarks: the inferior border of the mandible and the intertragal notch on the outer ear, which will be the target for the tip of the needle. The patient must open very wide. The needle penetration point is leveled with the maxillary occlusal plane and mid-facial lingual on the maxillary second molar. Note the point of penetration. The needle is directed to the intertragal notch and extended to the depth of the needle, which may or may not contact bone. The solution is deposited in this region that is more proximal and includes more sensory nerves. However, the long buccal usually requires a separate injection adjacent to the mandibular second molar. The echinocele technique. This technique is an effective and useful anesthetic means for a patient with trismus. In other words, it is good for patients who cannot open their mouth wide enough for the conventional approach. As seen on the skull, the syringe handle is parallel to the occlusal plane and is about the level of the mucogingival junction. The needle is directed straight posteriorly and at about 3/4 of the length of the needle. In a patient, it is again about the level of mucogingival junction and parallel with the occlusal plane. The needle is inserted at this level and posteriorly to about 3/4 of its length. The anesthetic is then slowly injected. The intraosseous injection. This is a supplemental injection with a rapid onset, and it is used when conventional injection gives inadequate pulpal anesthesia for teeth with vital pulps. This injection usually produces tachycardia, so the patient should be forewarned. There are commercially available devices from Stabident. The perforator and a matching ultra-short needle are shown here. If the premolar is to be anesthetized, the perforator is positioned at approximately a 45-degree angle to the bone. After penetration, the perforator tip drops into the medullary space. Note that on the mandible, the cortical bone is dense and it increases in thickness to the posterior. This is why the posterior mandible is difficult to penetrate with the perforator. This shows the location of penetration, which is in the interradicular space with the attached gingiva slightly apical to the cervical margins of the crowns. The perforator or number 2 round burr is positioned and advanced slowly. Use alternating pressure or a type of pecking action. If the perforator is not advancing, it has become dull and must be replaced. If it is not replaced, the perforator may bind and break or create frictional heat and burn the bone. The perforator has been replaced and this alternate pressure is continued until the perforator drops through the cortical plate and into the medullary bone. The needle must be positioned exactly in the same spot and in the same orientation as the perforator. Otherwise, it will not penetrate and be in proper position. Some maneuvering is often required. Place the needle to its hub against the tissues to minimize leakage of anesthetic into the oral cavity. Approximately a half cartridge is injected under some back pressure. Note the blanching of the mucosa. The X-tip is a combined perforator and a sleeve through which the needle is placed. This is generally effective and simplifies needle positioning. One problem is that there is a greater likelihood for the anesthetic leakage around the opening and into the oral cavity. The periodontal ligament injection. This is a supplemental injection that is used when the conventional approach fails to give adequate pulpal anesthesia in teeth with vital pulps. This injection is into the periodontal ligament space and is interproximal and never on the facial or lingual orfication. It is repeated on both the mesial and distal surfaces. A hemostat is a very useful adjunct to help support and direct the needle. This shows how the needle is positioned into the interproximal space. It is supported and aligned with the thumb and forefinger, which gives support to the needle. In a patient, the thumb and forefinger are supporting and directing the needle. When injecting, strong resistance is necessary on the syringe handle. This requires as much force as possible with the thumb. First the mesial, then followed by the distal insertion with strong back pressure. It has been reported that there is some post-injection pain, but it is mild. This is not a single tooth injection and will frequently anesthetize adjacent teeth. This is a safe injection with relatively little tissue damage. Be sure the patient has safety glasses and that his or her eyes are closed, as carpules have been known to shatter. The intrapulpal injection. This is a supplemental injection and is used as the last resort to obtain anesthesia in teeth with vital pulps. The needle is bent at a 45-degree angle using the needle cover. The needle is placed directly into the pulp chamber or into the canal, and it should bind upon the walls of the exposure site, which may require using different needle gauge sizes. Back pressure is required for successful anesthesia. There should be definite resistance, at which point the patient may react. This usually indicates success. It may be necessary to repeat the injection in each canal separately. The infraorbital injection. It is a substitute for conventional infraorbital technique, which requires passing a needle through inflamed tissue and a hard-to-locate target. This is useful for a patient with acute apical abscess in the anterior region. The infraorbital injection is best followed by an intraoral local infiltration at the periphery of the abscess. The target is the infraorbital foramen, which is directly below the rim. The solution will be deposited at the foramen and not into the infraorbital canal. This anesthetizes the anterior superior and middle superior nerves. When the patient looks straight ahead, the infraorbital notch can be palpated directly below the pupil and below the infraorbital rim. This shows the site of the injection. Scrub the area with betadine or alcohol for surface disinfection. Place the index finger at the infraorbital foramen. With the finger in position, insert the needle a slight distance into subcutaneous area and inject very slowly. This requires about 1/3 of a cartridge of anesthetic. Be certain that the tip of the needle contacts bone in order to deposit the anesthetic solution immediately adjacent to the foramen and not into the epidermis. After withdrawing the needle, note the wheal and the small bleeding point, which also indicates the site of needle penetration.